So the next panel is going to be about bridging evidence with the real world of the community and clinical practice. So I'm going to be your facilitator for the next 45 minutes, and we're going to be a PowerPoint-free presentation, except for this here. So no more PowerPoints. And we have 4 presenters here, and to the person on the sound, they're going to be doing their presentations from the mics here. So for the video people and the sound people, we'll be focusing here. So I hope at the end of this presentation, or at the end of the panel, you will have been given some great examples of how current rehabilitation research in HIV and aging is having an impact on persons living with HIV, and we're also going to have a section on where we should be going over the next 2 to 5 years as far as research. So I will be posing a question to each of our 4 panelists, and they will have 4 minutes. And Kate is our timer there, and they will tell us their story. And then at the end, there'll be one quick final question for everyone. And then we'll open it up for some audience questions or comments before we wrap it up. So you can read their full bios in your program package, but I'll do a quick introduction in their order of presentation. First is Chris Lucas, who's an HIV-positive volunteer at 9 Circles, who we've heard about this afternoon here in Winnipeg, and he'll be giving you a personal perspective on aging with HIV. Sue Chan, Carusone, at the end there. She's the rehabilitation research lead at Casey House in Toronto, and she will explore some of the complexities for patients and interventions in improving outcomes in HIV. Alan Casey is a physical medicine and rehabilitation physician at Health Services Center here in Winnipeg, and he'll be bringing us the physician's perspective on clinical intervention. And Puja Ahluwalia, a physiotherapist coordinating the Equitable Access to Rehabilitation Project at CIHRRC, will address some of the policy issues around services and accessing them, plus some information around knowledge translation for rehabilitation research evidence. So Chris, my typo there. Okay, I'm going to start off with you, and I'd like you to tell us a little bit about your own personal experience with aging with HIV, and in particular, how you see where rehabilitation research has affected your own interaction with either clinical practice or community service.
That's a loaded question. Okay, hi everybody, I'm Chris, and I've been positive since 1986. It's been a long 30 years, I'll put it that way. I came down with a secondary illness in 2007 called PML, Progressive Multifocal Leukoencephalopathy, for those who don't know what PML is. It's extremely rare and very debilitating. Over the last 8 years, I've noticed that in Winnipeg, our occupational therapy, thanks to 9 Circles, has been wonderful. But for rehab, I'm finding it very difficult. The words HIV rehabilitation, that's all new to me today. I've never heard that before, so let's take it from there. HIV rehab. I go to my doctors quite often and I'll say, look, I have pains in my legs, I have pains in my back, I have pains in my arms, and they send me off to the rehab. Here in Manitoba, if you have no extended health coverage, no extended benefits to the company you're working with, you're limited to 12 physiotherapy appointments per year, from what I understand. What Manitoba does, or our physiotherapy department has done, is crammed all 12 of those appointments within 4 to 6 weeks of you going to see them. Well, that doesn't help a guy like me. I have balance issues, I have mobility issues, I have dexterity issues, and I have coordination issues. And because of all those things, I need somebody to be following me on a regular basis. So if I'm only allowed 12 visits a year, then give me one a month. Have somebody follow me each month, give me a list of exercises to do, and then go ahead and do it. Come back to them in a month, find out if I'm on the right progress or on the right path. So far, all the rehab that I've done has been on my own dime. I've gone out and done my own walking, I've done my own part-time work over the last 8 years. I help a friend out with landscaping, so it allows me to get out there and do a little bit of extra work than what I'm actually capable of doing. My biggest fear for getting full-time or even part-time employment is this episodic disability that I have. Some days are good, other days are really, really bad. And I can't tell which one's going to be which. I just got to go with the flow. It's been very, very, very difficult. Try to explain to your family that you can't go here, you can't go there because of your problems, and they don't want to know about it. You're trying to explain your situation, nobody wants to hear it, right? So I lucked out. I live in a lower income place, so that's good. It's a 55 plus complex. That's a good benefit. So now I'm seeing the 1 minute sign, so I'm gonna cut. I'm gonna shut myself up here right away. So, but really, it's been a wonderful experience. I'm glad to be here to share this with you guys. Thank you.
Thanks, Kristen. I'm sure later there'll be more through the questions. You'll have a chance to speak again. So now, Sue, can we hear from you as to what you've learned about how rehabilitation research has impacted the clinical practice and community services with the residents and the clients that you see at Casey House?
Thanks, Larry. So I think before I can answer that question to how rehabilitation research has impacted Casey House, and what I'm going to sneak in there is also our desired role for involvement and hopefully our impact on rehabilitation research. Is to give a bit of context to Casey House. So currently Casey House has 13 inpatient subacute care beds and also provides community and outreach programming. So right now we have limited access, what's eligible through CCAC, Community Care Access Center, and on a consultation basis to PT and OT. But within the next 12 months, Casey House will be opening a day health program and expanding the interdisciplinary team to include permanent positions for OT and PT. So we're really excited about that and hoping to kind of see that as an opportunity to be involved more in rehabilitation research as we move forward. So that's the context of Casey House kind of structurally, but then there's the context of the clients that we provide care for at Casey House. And I would say on average, clients are living with 5 or more comorbidities in addition to HIV, that 90% have a history of some mental health diagnoses, at least 80% have some substance use, and at least 20% are unstably housed. So these are the type of people that randomized control trials and clinical guidelines don't really address. They're not speaking specifically to those clients, and kind of taking what's out there and applying that, it can be challenging. So we have participated in some of the research that is being talked about already today, and Kelly and I also co-supervised a group of physio students last year, and what we did a qualitative research study to complement Kelly's intervention work on community-based exercise intervention, and to kind of take a step back and saying, okay, well, in these complex clients, well, maybe we should actually be looking at readiness to exercise, and what are the facilitators and barriers for people to actually consider an exercise program, not what impact can it have if you can actually get them out there. So I think what impact has it had? on Casey House in general, our involvement in rehabilitation research, I think, is on an organizational level, but also on an individual clinician or staff level. And what I also think as a researcher, the importance of involving staff in research changes how they look at their work. It changes how they think about problems that we're facing and preparing for the future and shifting the programs that we provide. So I think that kind of capacity building is a really key impact, I would say. And I think as we move forward, as I said, in the day health program, Kelly and I are looking to co-supervise another group of students, and hopefully we can reach out to Tammy at 9 Circles and really understand kind of the best way of integrating PT and OT within this interdisciplinary team and to make the most of that. So.
Thank you, Sue. Now, we turn it over to Alan, and we're going to get a different perspective on rehabilitation research, and this is from a physician's perspective.
Thanks, Larry. I'd like to clarify a little bit. I work as a rehabilitation physician, primarily working with people with spinal cord injuries and neuromuscular disorders. You see some folks with HIV and the consultation purposes, but it's not my highest focus in practice. That my experience has been more being involved with Quaker. I've been on the board for the last 6 years. I'm given some panels and some challenging panels along the way as well. But the most complex or challenging talk I ever gave was actually at 9 Circles to a client support group there, which was very interesting. I was there to try to talk about what rehab could do. Most of the people there had never thought about it or didn't even think of the term at all, let alone realize that they kind of already were in a rehabilitation program, but they just didn't ever conceptualize it as that. The reason it's so complex is in part that communication. There were people in the room who had greater knowledge of HIV than most people in this room, and other people whose HIV was the least of their problems. They had a plethora of other things, whether it's developmental delay or psychiatric pre-existing issues or socioeconomic issues or whatever. And the challenge was just trying to communicate. And I think that's the challenge in HIV rehabilitation research is trying to communicate that for people understand what what rehab and HIV, how they interrelate. For people living with HIV, what rehabilitation can do for them, for rehabilitation professionals, especially those in the aging sectors, learning from people with HIV and about HIV and not freaking out about it. And probably most importantly, the HIV direct care providers, which are always an underrepresented group here, people that, again, like Dr. Flute said, referrals to you are always labeled perhaps not what the actual problems are. And the understanding of what we have actually to do is very challenging. And then finally, the communication is sort of the rehabilitative economics, trying to prove that actually we can make a difference. And Darren's work was great to see today, because that actually will make the biggest difference to the people who count, which is generally the funders. So, yeah, thanks.
Thanks, Alan. Now, last but not least is Puja. We're going to be looking at you to give us a little bit of two things. One is your project on access to rehabilitation, but also in doing that, what has been your experience on translating research knowledge to the community, whether it be the ASOs or PHAs or the broader health community?
Yeah, so thanks, Larry. So it's been great today because every single presentation sort of strengthens the idea that we do need access to rehabilitation for people living with HIV and people who are aging with HIV. We know Canadians are aging, our population as a whole is aging, and we know now people with HIV are aging and most often with some comorbidities or multiple comorbidities, with levels of disability or episodic disability. And Chris, thanks for your examples. That really sort of describes what life is like. And we also know that rehab decreases disability and helps maximize functioning for people living with chronic health conditions, including HIV. And so we know all this in this room, but the problem is not everyone outside this room knows this. I've spoken with people working at HIV organizations to talk about one of the examples that Tammy and Kate brought up is how Quigger facilitates occupational therapy and physiotherapy practicum placements in HIV organizations. We work closely with the universities and the organizations. But sometimes we approach an organization and the response is, oh, our clientele is really complex. We don't have a need for OT. Yeah, that's my reaction as well. And so we need to really figure out a way to translate this information from this room out to the public, and that includes people working in the aging sector, people working in the rehab sector, and people working in the HIV sector. We all need to be able to talk about these issues together. So one of the things that we at Quigger are doing, one of the projects that I'm working on right now, just the title, it's kind of long, the Pan-Canadian Equitable Rehabilitation Network. And there's really early stages of development, but the goal is for it to be a national collaboration for people from all areas, including aging, including even beyond HIV, including chronic health conditions. Because if we get together, all of us, researchers, policymakers, rehab professionals, people with lived experience, and talk about what works, what doesn't work, and what avenues we want to push forward in. When we have a collective voice with HIV and other chronic health conditions, we can really sort of hopefully get someone to hear us, whether it's at the federal or provincial government levels, or whether it's even at the basic hospital level, trying to create a program like Darren's. If we could have that here in anywhere in Canada, that would be great. And we also need to sort of be able to educate, so that network will sort of create research opportunities and policy initiatives and sort of have a discussion available of what's working. We also need to work on the other side behind the scenes and educating people from all areas. So, which is with the role immersion placements, the OTs and the PTs, we can educate them, because when these programs are available in the community, these current students will be the practitioners working in these programs, and they need to know that they can make a difference in the lives of people living with HIV. And then we also need to work on educating people at HIV organizations. We've got great organizations like Fife House and Casey House and Nine Circles that know the benefits of rehab, but not everyone does yet. And then we also need to be a little bit creative. And sometimes we have to acknowledge that there are certain structures in place that we just can't break down yet. So Chris's idea of, if you get 12 visits a year, he would benefit from them one a month. And that's not an unreasonable request. That's working well within the constructs that we have. And so we need to sort of really be creative and work with each person individually and collaboratively to figure out what would work best. So we need to push against the barriers, but also work within them for the time being.
Thanks, Puja. Now, before we open it up for questions from the floor, we have one final zinger question for each of the panelists here. It's a quick snapper, so they only have 1 or 2 minutes. And it's going to start off the discussion, which I think Kelly's going to continue on later. And that is, from your perspective, what do you think should be the HIV rehabilitation research priorities for HIV and aging over the next 2 to 5 years? So, it doesn't have to be in any particular order. Whoever wants to kick it off.
Well, I talked about a few already, but I think overall demonstrating successful models across the community that actually work are going to be very, very helpful. Because then you can take it back. You can take some of the vocational rehabilitation programs back to different human resource managers and take community support organizations that are working, and people can emulate them or adapt them for their own local circumstances. So I think that's the best option.
Yeah, I'm gonna back on what he's saying is we really need to, the next 2 to 5 years, the policy level changes we may have are not going to be as big as we want to see. So we really need to figure out what's working right now, and then how can we replicate it in other contexts. We know we can't just take one program from Toronto and put it into Winnipeg because there are different influences. So yeah, take a program that works well. 9 Circles sounds like a great program, and then see where else can we implement that, and what changes we need to need, so we're not forgetting about the people that need the services right now.
What I have, and I'm not pretending to be objective when I state these priorities, but I think our ability to include and understand complexity, so complex patients or clients within research for the goal of improving care and outcomes for the very complex. And my second one, which is related to that, is I think how do we do better without doing more? So, with our current kind of fragmented system with people with 5 comorbidities, which has come up a lot today, is that they're referred to specialists, geographically very different providers who don't communicate, and that's not, and by referring to more doesn't necessarily mean a better outcome and could actually be detrimental. I think in really understanding priorities. So earlier what we talked about of really what are people saying that they want to work on, and really helping them achieve those goals, and that they're going to be a lot more motivated in making those possible if they're patient identified or person identified.
And I find HIV and aging, those 2 words never belonged together until recently. And here we are. I would just like to say that I need a better understanding from my doctors or from my healthcare professionals to help me navigate the sea out there of trying to get the services I need as an aging HIV positive man.
Okay, thank you very much, all 4 of you. I hope the sound is the sound bad for you people as it is up here for us? I get a huge echo out here. Oh, okay. Then it's just me, maybe. It's not. Oh, okay. Well, good. You guys are in a much better state than I am up here. I'm zinging around with sounds coming everywhere. Okay, we have a bit of time, so we'd like to give the opportunity to the audience to either ask a question of one of the panelists or to add a comment yourself to the discussion of how research has impacted upon clinical service or community service. And when you have the question, if you want to direct it to a particular individual, please do so.
Is it on? Chris, I want to address you because I want to say, if nobody said it to you before, I want to commend you on how courageous you are. Basically, I'm going to put my qualitative interviewer hat on, and at one point you said that you were really happy that you were in a 55-plus building. Okay, so can you tell me why you feel that way, and what kind of impact being in that place has had on you?
I guess it was, I never thought I'd ever nest anywhere, like set my roots down anywhere, and this is probably the first time in all these years that I've ever decided to do this. And I lucked out. I got a corner apartment. It has hand grips for my bathroom. It allows me to have a garden outside that I really take a lot of pride in every year. And it's affordable living. And that's what we need. I need to be able to know that I can age in my environment and do it comfortably. And being where I am, I put up with a lot of stuff there, but it's pretty much okay on the downside. So, yeah, it's being able to age and live in the spot that I'm choosing to live, and I think that's vitally important.
Thank you for the presentation, all of you. It's really quite refreshing not to have PowerPoints as well. This is really a comment, and it stems from Puja's and Chris's comments as well. Because I think one of the things we have to do is teach people living with HIV how to advocate for rehabilitation. If they don't know what it is, they can't advocate for themselves. And so, again, I guess a bit of shameless promotion, but one of our projects that we're doing now that Larry's been involved in is trying to develop modules that can be used by people living with HIV to help train them how to advocate for themselves for rehabilitation and when it's appropriate to advocate for rehabilitation, and the skills to go to your physician and say, listen, I think I need an OT because this is why I'm having issues. And so I think it's not just the health providers and the policymakers that need education, it's people living with HIV.
One of the benefits that we've seen from the occupational therapy placements is people of the HIV organizations have reported back to us is that just the information awareness raising of what OT is for their clientele and for their staff, because most people unfortunately don't know.
We are professionals really bad, so very humble.
Especially Canadian ones.
Hello, Darren again. I've got a question again for you, Chris, and also Puja, around what you were saying around accessing physiotherapy, for example, and how you was entitled to those 12 sessions. With my service, we basically offer unlimited number of sessions. However, maximum that people attend is on average 6. People don't exceed that, even with the availability and flexibility to have them whenever they want. So I just wondered whether you could educate me on what's going on with those services and why there seems to be such tight, stringent restrictions on what you can and can't have. Obviously, I'm guessing this is a government-enforced system, but could you tell us more about that?
I don't fully know why. I know each province has very different restrictions on what is publicly funded, and they range between age limits. So in Ontario, if you're under the age of 18 or over the age of 65, you can get services, and you can also get the minimal services if you're on any financial assistance. But the numbers they choose and how often they can happen is variable and odd. Like, unfortunately, I don't have a better answer.
It varies. Certainly, certain diseases or issues would be able to obtain different types of therapies. So we have a day program that can come to quite extensively after an acute issue, there's one heart issue or stroke or whatever. But most healthcare is it's incident focused. It's not dealing with chronic disease management over the long term. And we're very poor at doing that, even though most diseases or 90% problems are chronic disease. The whole healthcare system is funded and organized.
Yeah,
exactly opposite.
You tend, after an acute event, surgical or any other acute event, you will get, or you will have most often have the opportunity to get concentrated services. But once you're so-called stabilized.
Incredible. I can vouch for that. I was bouncing off a wall 7 years ago, and they got me walking again. Although I was on a walker for a year, a cane for 5 years after that. Yeah, I have to praise the outpatient physio at our hospitals. They're incredible. It's the inpatient. It's when you're as an inpatient, it's incredible. As an outpatient, it's not. So.
Hi, Ron Roseness. First of all, thanks to all the panelists, and also thanks to you, Chris, for taking on the job of representing us this afternoon, as those of us who are, aging with HIV. As I listen to the conversation, though, what always sort of comes home to roost for me is this increasing pile of bills that I'm looking at on an annual basis for all the services that I want and need that simply aren't covered. So I know it's great when you've got these outpatient services, and it's great when they're covered, but we continue to live in a country where it's a big patchwork quilt. So the question, that I want to raise, and because of my long history, if you will, advocating for access to coverage in the healthcare system, is to challenge us, including myself, and the work I do as a volunteer in Quigger to ask the question, what can we do and be doing better to ensure coverage for a lot of services that we would like access to? I'm using osteopathy these days. It's out of pocket. I have tremendous dental expenses. They're out of pocket. I'm using cold laser therapy for pain relief for a torn rotator cuff. It's all out of pocket, and it's very expensive. Now, you know, there are tremendous arguments to be made always for covering modalities or therapies that are on the preventive side and that prevent us having to go into the acute part of the healthcare system later on. So I would like to hear anybody else's comments on how we could be doing, using research to advocate for more coverage within the healthcare system of the things we particularly need as we're aging.
Yeah, I think to effect change, you have to demonstrate proof of effect as well as proof of lessening cost, and proof that it's feasible to change the current system, which are all very challenging to kind of prove. Funding is sort of a static funding until it's within the envelope, and if you have to cut something to fund something new, so that's always the challenge. If you can prove it would do something useful, people listen.
I think the added difficulty of proving it can do something useful is that taking away money from acute services or emergency services will not do something detrimental. It also needs to be proven. The thought, people like, if you go into preventative care, you've got to take something out of reactive care or some other area, and you can't. People don't like losing money in certain areas, and that's a really difficult barrier to sort of go against. And I think politically, it's also if you were to change the system to be more preventive, which I would love, it would be a huge influx of money in the beginning, and that's often a difficult conversation to have. Not that we shouldn't have it, but that's very difficult to have, I think.